Welcome to this Anatomy and Physiology Masterclass on the respiratory system, relevant for various nursing and medical exams. Our objectives include exploring the anatomy of the upper and lower respiratory tracts, the physiology of ventilation and gas exchange, lung volumes, and clinical conditions like COPD and hypoxia. We will also cover nursing assessments and practice previous year questions. The main functions of the respiratory system are gas exchange, pH regulation by controlling blood acidity, protection against pathogens, vocalization using the larynx, and olfaction or the sense of smell. Remember that the respiratory system is the fastest mechanism to regulate blood pH. The respiratory system is anatomically divided into the upper respiratory tract, which includes the nose, nasal cavity, and pharynx, and the lower respiratory tract, which comprises the larynx, trachea, bronchi, bronchioles, alveoli, and lungs. The nose and nasal cavity function to warm, moisten, and filter air. Key structures include the septum, turbinates or conchae that increase surface area, and cilia. Kieselbach's plexus is the most common site for epistaxis or nosebleed. The pharynx, or throat, is a 12 to 14 centimeters long passageway for both air and food. It is divided into the nasopharynx, which handles air only, the oropharynx, for air and food, and the laryngopharynx, which divides into the esophagus and larynx. The larynx, or voice box, connects the pharynx to the trachea. Its functions include air passage, voice production, and preventing food entry into the lungs. Key cartilages are the thyroid, the cricoid, and the epiglottis, which closes the airway during swallowing. Let's review a previous year question. Which structure acts as a lid to prevent food from entering the trachea during swallowing? The correct answer is B, the epiglottis, which is an elastic cartilage covering the laryngeal inlet. The trachea, or windpipe, is a 10 to 12 centimeters tube supported by 16 to 20 C-shaped hyaline cartilage rings. These rings are open posteriorly to allow esophageal expansion during swallowing. The carina is the sensitive ridge where the trachea splits into the bronchi. Comparing the right versus the left bronchus. The right bronchus is wider, shorter, and more vertical, resulting in a higher aspiration risk. The left bronchus is narrower, longer, and more horizontal. Previous year, question 2. A child accidentally inhales a peanut. Where is it most likely to lodge? The answer is B, the right bronchus, due to its wider, shorter, and more vertical structure, providing a straighter path for foreign bodies. The right lung has 3 lobes and is heavier, while the left lung has 2 lobes and the cardiac notch. The lungs are encased by the double-layered pleura. The parietal layer lines the chest wall, and the visceral layer covers the lung surface, with fluid in the space in between to reduce friction. The alveoli are the functional units of the lungs where gas exchange occurs. Type 1 pneumocytes provide structure, and type 2 pneumocytes secrete surfactant, a lipoprotein that reduces surface tension and prevents alveolar collapse, or atelectasis. Previous year, question 3. What is the primary function of surfactant in the alveoli? The correct answer is B, to prevent alveolar collapse by reducing surface tension at the air-liquid interface. Ventilation involves 2 phases, according to Boyle's law. Inspiration is active. The diaphragm contracts, chest volume increases, and intrapulmonary pressure drops. Expiration is passive. The diaphragm relaxes, chest volume decreases, and intrapulmonary pressure rises, forcing air out. The primary muscle of respiration is the diaphragm, responsible for 75% of airflow supplied by the phrenic nerve. External intercostals also elevate the ribs. Accessory muscles, like the SCM and scalenes, are used only in distress or for forced expiration. Respiration includes 3 processes. Ventilation is air movement, external respiration is gas exchange between alveoli and blood, and internal respiration is gas exchange between blood and tissue cells. All gas exchange occurs via diffusion from high to low concentration. Oxygen is transported mostly bound to hemoglobin, 97%. Carbon dioxide is primarily transported as bicarbonate ions, 70%, with smaller amounts bound to hemoglobin or dissolved in plasma. Quick check. Which nerve supplies the diaphragm? The answer is the phrenic nerve. Lung volumes include tidal volume, the air exchanged during normal breathing, inspiratory reserve volume, the extra air inhaled, expiratory reserve volume, the extra air exhaled, and residual volume, the air remaining after maximum exhalation, which cannot be measured by simple spirometry. Lung capacities are combinations of volumes. Vital capacity is the maximum air exhaled after maximum inhalation. Total lung capacity is the total air the lungs can hold. Functional residual capacity is the air left in the lungs after a normal expiration. Previous year, question 4. The volume of air inspired or expired during a normal respiration is called. The answer is B, tidal volume. Neural regulation of breathing is controlled by centers in the brainstem. The medulla oblongata is the primary respiratory center, controlling the basic rhythm. The pons contains the apneustic center, which prolongs inhalation, and the pneumotaxic center, which limits inspiration and controls rate and depth. Chemical regulation of breathing involves chemoreceptors. Central chemoreceptors in the medulla are sensitive to CO2 and pH, which is the primary drive for healthy individuals. Peripheral chemoreceptors monitor low O2, which becomes the hypoxic drive in COPD patients. Previous year, question 5. The respiratory center involved in controlling the rhythmic cycle of breathing is located in the medulla oblongata. The correct answer is C. This slide provides a table of normal values for arterial blood gases, which are essential for assessing acid-base balance and oxygenation. Normal breath sounds include vesicular, which are soft and low-pitched, and bronchial, which are loud and high-pitched over the trachea. Adventitious or abnormal sounds include crackles, wheezes, and stridor, the latter indicating a possible upper airway obstruction emergency. In COPD, patients may be blue bloaters with chronic bronchitis or pink puffers with emphysema. Nursing interventions include low-flow oxygen, the tripod position, and pursed lip breathing to manage this condition. It is important to recognize the signs of hypoxia. Early signs include restlessness, anxiety, and tachycardia. Late signs are more severe, such as bradycardia, extreme restlessness, and cyanosis. Previous year, question 6. The earliest sign of hypoxia is B, restlessness. A pneumothorax is air in the pleural space, leading to lung collapse. Signs include sudden chest pain, dyspnea, and absent breath sounds on the affected side. Attention pneumothorax is an emergency with possible tracheal deviation. Treatment involves a chest tube with water seal drainage. Tuberculosis, caused by Mycobacterium tuberculosis, is transmitted via airborne droplets, requiring an N95 mask. Symptoms include a cough lasting more than 2 weeks, night sweats, and weight loss. Screening is done with the Mantoux test, and treatment involves DOTS therapy. Previous year, question 7. A Mantoux test is considered positive in a healthy individual if the induration is B, greater than 10 millimeters. For ineffective airway clearance, nursing interventions include positioning the patient in high Fowlers, promoting hydration to thin secretions, performing chest physiotherapy, suctioning if necessary, and nebulization treatments. Key suctioning guidelines include pre-oxygenating with 100% O2 and maintaining a pressure of 80 to 120 millimeters of mercury for adults. Insert the catheter without suction, applying it only while withdrawing for a maximum of 10 to 15 seconds per pass. Wait 30 to 60 seconds between passes. Previous year, question 8. While suctioning a tracheostomy, the maximum duration for each suction pass should be B, 10 to 15 seconds. This slide outlines various oxygen therapy devices, their flow rates, and the expected fraction of inspired oxygen, or FiO2, they deliver. Bronchoscopy is the visualization of the bronchi. Post-procedure priority is assessing the patient's gag reflex before offering food or water. Monitor for laryngeal edema, stridor, and note that a small amount of blood-tinged sputum is considered normal. Thoracentesis removes fluid from the pleural space, often for pleural effusion. Positioning involves sitting upright and leaning forward. Post-procedure care includes positioning the patient on the unaffected side, obtaining a chest X-ray, and monitoring for respiratory distress. In an asthma attack, which involves bronchospasm and inflammation, a silent chest with no wheeze is a severe sign of impending respiratory failure. Management includes a SABA, like albuterol, corticosteroids for inflammation, and oxygen therapy. This video continues with respiratory pharmacology. Let's review lung volumes. Vital capacity is the total of tidal volume, inspiratory reserve volume, and expiratory reserve volume, equaling approximately 4,600 milliliters. High-yield revision points include the Adam's apple is the thyroid cartilage, the larynx is the voice box, and the trachea is the windpipe. Remember, the right lung has 3 lobes, and surfactant prevents alveolar collapse. More key points. Tidal volume is 500 milliliters. Restlessness is an early sign of hypoxia, while cyanosis is a late sign. COPD patients rely on the hypoxic drive. Suctioning should last a maximum of 10 to 15 seconds. In summary, the respiratory system is vital for gas exchange and pH balance. Essential nursing skills include identifying abnormal breath sounds, managing oxygen therapy, and understanding critical conditions like COPD and pneumothorax.